European School of Oncology, E-session will start at 6:15 p.m. Central European Time. Please hold on. European School of Oncology, E-session will start soon. Please hold on. European School of Oncology, E-session will start at 6:15 p.m. Central European Time. Please hold on. School of Oncology. E-session will start soon. Please hold on.
Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the E-session 534. Today's session is, the role of ECMO in the COVID-19 era. Please note that this activity is CME accredited. At the end of the presentation, by closing the webcast window, you will be directed to the CME evaluation and multiple choice test. Mastermind competitors will be prompted to start the quiz, after having completed the evaluation. As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the bottom of the page. Questions will be received by Dr. Luca Bertolaccini, of the European Institute of Oncology, from Milan, Italy, who will discuss them with Dr. Pierre-Emmanuel Folkers, of the Nouvelle Hôpital Civil, Strasbourg University Hospital, from Strasbourg, France. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Folkers. Doctor, your line is now open.
Sorry, Dr. Falcots, we cannot hear you, so please unmute yourself.
Do you hear me now?
Yes.
Oh, okay, sorry.
Thank you.
Hello, everybody who were online, all the people who are online. I first want to thank Luca Bertolaccini for having invited me for this session. Initially, it was planned before the COVID era, and I would have been pleased to talk about the database, our activity in the ESTS database, which is mainly related to cancer. However, due to the recent event we have to face, A lot of things have changed, and my topic today will be about the role of ECMO in the COVID-19 era. I think it will last about 20-25 minutes, and then I will be very pleased to answer any question you may have. So let's begin. Concerning the COVID-19 era, most of the available reports come from Chinese or Italian Chinese or Italian literature. What can we find concerning the COVID era and the ARDS patients? In those reports, it is admitted that 15 to 32% of the COVID-19 patients that had COVID-19, they develop an ERDS, acute respiratory distress syndrome. And among those patients, there is a very high rate of mortality, approximately 50 to 60% of mortality. In the meantime, the WHO, World Health Organization, they advocate for the use of ECMO in this particular setting of COVID-19 pandemic. They wrote and they published an interim guidelines that recommend ECMO, and in particular veno-venous ECMO, as an end stage or rescue therapy in the most severe cases of patients that had a COVID-19 related ERDS. However, and it is the purpose of my talk, of today's talk, the benefit of ECMO, and in particular veno-venous ECMO in ERDS, it remains today's controversial. We have some observational data dating from 12 years ago from the previous H1N1 outbreak in 2008. At this time, there were use of ECMO for the cure of rescue therapy in H1N1 pandemic flu, but it was not possible to prove an impact on mortality thanks to ECMO. More recently, there are only few data available in the present concerning the present pandemic, and with a very short follow-up concerning ECMO and ERDS. And last but not least, the current pandemic context, as each pandemic, we have to face limited medical resources. And one question that may arise is that, is it worth to use ECMO instead of other medical resources in the framework of ERDS? So, the aim and the main objectives of today's talk will be first to describe the different types of ECMO we can use in the particular setting of the COVID-19 era, and then to highlight some specific and interesting features regarding to COVID-19 pandemic. And those, the aim will be for to have an accurate, a very precise, accurate selection of the COVID-19 related ARDS patients that may be good or excellent or good candidates for an ECMO support. First, the general context of ECMO. ECMO, it means extracorporeal membrane oxygenation. It is a life-saving therapeutic option. It is, in fact, a very simplified extracorporeal circuit. You have the cannula, and we will talk about them later on. And you have an oxygenator and a pump. First, the oxygenation. The blood in ARDS patients has to be saturated in oxygen, and the oxygen comes from the blood flow through the pump that you are able to see on the upper and right part of the slide. The blood, in case of ARDS patients, has also to be decarboxylated. And the decarboxylation, it comes from the gas flow in the oxygenator. And you see an example of oxygenator at the lower part of on the right part of the slide. Importantly, a partial bypass is most of the time sufficient enough, and a bypass of 20 to 30% of the blood flow. It depends on the level of the decarboxylation you want to have and the level of oxygenation you want to reach. But in, not very severe ARDS, 30% of the blood flow has to be derived, and for an optimal oxygenation and decarboxylation. The cannula now. Where to implant the cannula? There are different types of ECMO, and I will highlight today only the different types of ECMO in the framework of ARDS, not in the framework of post-op surgery or as a bridge to lung transplant, just in the framework of ARDS. First, you can use, and above all, and we will see that later, I will insist on this point, the preferred type of ECMO is veno-venous ECMO, VV ECMO. It means that the drainage is done through a vein and the injection is done through a vein, veno-venous ECMO. The first letter, the first V, mean the drainage always, and the second letter mean the injection always. Among those veno-venous ECMO, I will highlight an interesting kind of ECMO, which is the single station jugular ECMO called, thanks to the Avalon cannula, which is a double lumen cannula, single insertion, single station, but double lumen. In the setting of ARDS, in particular cases, in ARDS associated with cardiogenic shock, you can use veno-arterial ECMO, but in our experience, recent experience, it was not the most prominent type of ECMO that we use. The other type of ECMO were not used in the setting of severe ARDS related to COVID, arteriovenous ECMO or awake ECMO. So I will skip on the last two for you to remember. Two types of ECMO that can be used in ARDS. The most interesting one is the veno-venous ECMO, and the most widely used, veno-venous, in some cases, veno-arterial. So, as I told you, there are different types of ECMO that apply for different situations. And this is a very global and general slide. And in the particular case of ARDS, we have to face with hypoxic failure. So, in those cases, the prominent support was the veno-venous support, as I told you, pump-driven, thanks to extracorporeal circulation. In case of hemodynamic instability that we might encounter, it was we can choose, but it was not very frequent, the veno-arterial support. That can be later on switched to a veno-venous support. But for you to remember, ARDS related to COVID venous support pump driven thanks to extracorporeal circulation. So this slide to highlight the framework of veno-venous ECMO during the COVID-19 last COVID-19 pandemic. Thanks to this veno-venous ECMO, we were able to provide an adequate oxygenation for the patient, an adequate decarboxylation, and this can be done through double or single peripheral cannulation. On the left part of the slide, you have a double cannulation, veno-venous ECMO. I mean, the drainage is done via the groin in the inferior vena cava through the femoral vein, drainage, pump, oxygenation, and the re-injection is done. The oxygenated blood is injected via the cervical approach via the jugular vein. Femoro-jugular veno-venous ECMO. We are also able to use another interesting device, which is a double lumen cannula. The interest is that it let the groin free, and we have only one site of insertion, which is the neck. And thanks to this double lumen cannula, we are able to drain and derive the blood thanks to one of the lumen, and then always the same, the pump, the oxygenation, and the re-injection via the same cannula in the other lumen. What are the difference between double and single cannulation? Quickly, double cannulation, 2 sites. It takes a longer time for cannulation because you have to cannulate at the 2 sites. On the other side, it provides an higher flow and a greater oxygenation because you remember the flow is done via the pump, and if the flow is greater, the oxygenation is greater. However, as a side effect, you have a greater recirculation. It means that the oxygenated blood, which is injected in the right atrium, a part of this oxygenated blood is drained, aspirated in the via the drainage cannula. That's why it has been developed thanks to the industry, the Avalon device, which is a single lumen. It has to be inserted under echo guidance. It has a lower flow because of the diameter. In the same cannula, you have two lumen, a lower oxygenation because of the lower flow, but thanks to its own shape, you have a less recirculation. So, and it let also the groin free, which might be interesting if you want to have an awake ECMO. So we have seen just to stop and to see where we are in the context of the pandemic, veno-venous ECMO, single or 2 cannulation sites. What is the most prominent, most interesting vascular access? No longer open access. The approach is a percutaneous one, thanks to ultrasound guidance with the Seldinger technique. It is rather easy, rather safe. Importantly, if you want to use the Avalon cannula, you have to be followed and you have to work under with the with an echographist, it is very important to perfectly place the cannula in the inferior vena cava. So the approach, the vascular access are percutaneous, Seldinger technique, and peripheral. You have at the bottom of the slide an insertion in the neck and in the groin. If you have any question, I think that's time. I've not seen anything. I can answer at the end. If not,
Pierre-Emmanuel,
yes.
We have a question from the audience.
For sure.
Our audience, it's a global audience, not only surgeons, but oncologists and so on. So the question is, who put the cannula in the patient, in the COVID-19 patient? The anesthesiologist, the surgeon, the vascular surgeon, who is... Thank you.
As we were in the middle of the storm in our department, and it is the case since 15 years, the thoracic surgeon implant the cannula in the intensive care unit in a multidisciplinary, teamwork with the intensivist at the head of the patient and the echographist, cardiologist or intensivist during the same procedure, helping us to place correctly the cannula. But from Strasbourg University, and as far as I know, in France, at least, the surgeon, they implant the cannula. It works the same way in Paris. They had an important, a huge number of patients, perhaps more than, not perhaps, more than 100, and they share the work. To achieve the best result, the surgeon implant the cannula, and the intensivist were at the same time at the bed of the patients to help and then to follow. But it is a real teamwork with the perfusionist, the surgeon, the intensivist, and the echographist. We have created a special unit to be able, in our university hospital, to be able to take care of patients outside of the hospital and implant ECMO in our a large territory, perhaps, 100, 150 kilometers around our hospital. And if we have to do so, it is the surgeon and the perfusionist who take the ambulance or the helicopter to go and to the other hospital and bring back the patient to the university hospital. Was it clear, Luca?
Yes, absolutely. Thank you.
Could we move on?
Yes.
Okay. So now, a very interesting part, it is the implantation site. Where can we implant our ECMO cannula? The groin. The groin was, and will be the most frequently used because it is a very easy it has an easy access. It is rather rapid and fast to implant, and also because of the diameter of the vessel, which match perfectly, or more or less perfectly, with the cannula. Importantly, it is important to know and to keep in mind that it is far better and far safer to use the right side to implant the venous drainage. Right side femoral, most easier than the left side of the groin. I let that intentionally on the slide. It is very important to know that if you use the groin and if you want to implant a cannula in an artery, you have to put a shunt. A shunt is mandatory. Either you put it percutaneously, surgically, as you want, but if you implant a cannula in an artery in the groin, you have to put a shunt below to prevent an always possible ischemia. It is a kind of drama to have a patient cured from the disease, a cardiogenic shock, an ARDS, what you want, that has to be amputated of the leg. And believe me, it is seen even in very medically developed countries. So, to summarize, the groin is the most frequently used. You have here one of the first patients that had been implanted in the COVID-19 period. The old guy, 70 years old, severely obese, that has veno-venous, femoro-femoral ECMO. You see the drainage, the pump here, the oxygenator, and the re-injection in the other femoral vein. This is the perfect guy as recommended thanks via the ELSO and so on. Another possible implantation site is the axillar artery in case of veno arterial ECMO. It is interesting if you have to face with a patient with a peripheral vascular disease and an hemodynamic instability. Peripheral vascular disease, impossible to cannulate safely in the groin. You use the axillary artery. You have a few risks of ischemia. However, the implantation takes time. You have to go to the operative room. You have to insert a prosthesis. But it is very, very interesting because the perfusion comes via the truncus arteriosus, and you are able to perfuse the coronary artery and the cerebral vessels with oxygenated blood. That is not the case in those veno-venous ECMO. As I told you, another important implantation site is the neck. The neck, you have already understood that it can be used as when you want to use a single B station, groin and neck, or the neck by itself with the Avalon cannula. So the neck was widely used to be used in the pediatric settings. Since 30 years, 25 years, it is used in the setting of ECMO circuit in the adults. And the most prominent circuit is the femoro-atrial veno-venous ECMO circuits that give the better output in terms of oxygenation and in terms of flow. This is an very important, old but very important study lasting for more than 20 years, but they also nicely showed that femoro-atrial veno-venous ECMO circuit has the best outcome in terms of flow, so in terms of oxygenation. Since 10 years, 10, 12 years, you have the new Avalon Elite cannula. I already told you it is a double lumen cannula. It can be done percutaneously. It is quite convenient to use it when you are not in your hospital, when you are bringing back a patient from another hospital, when you it is also easily used in the framework of a lung transplantation. As a bridge to lung transplantation, it provides an adequate oxygenation. You can have an awake strategy. You can the groin is free, and the patient could work with the physiotherapist. We have used this cannula in the setting of the COVID-19 pandemic with some success. A few words on the cannula. As I told you, double lumen. You have the cannula has to be placed the tip in the inferior vena cava. You have some small hole for the inferior vena cava, superior vena cava. That is the drainage cannula, and then the re-injection is done via the other lumen through the tricuspid valve. Thanks to that, you have no recirculation, and it provides an adequate oxygenation. The future would be to develop a neck exit cannula. It is not available in Western Europe, for instance. Always the same thing. So you see that the insertion is rather easy. When you know how to do it, it is less than 30, 40 minutes. It can be done in the intensive care units. It is not mandatory to go to the OR, but what it's mandatory is to perform the procedure with an echographist. The insertion of the cannula, you have not to be afraid, but it is a 31 French or 27 French, rather a big cannula in the neck. You see here the difference in the color of the blood. The non-oxygenated blood, it is blue, and then the pump, the oxygenator, and then the oxygenated blood in the same the other lumen of the same cannula. Blue blood drainage, red blood injection. You have here some pictures of the echography. The cannula in the right atrium in the superior vena cava, and here another picture where you see the tip of the cannula in the inferior vena cava. Before the last part of the talk, are there any questions?
No.
No?
No.
Do you allow me to continue?
Yeah.
Okay. So, specifically some features connected to ECMO and the COVID-19 pandemic. The American Journal of Artificial and Intensive Artificial Organ published during the month of April some recommendations concerning the implantation of ECMO. Among the authors, you see our colleague, Dr. Swishenberger, that take part in the development of the Avalon cannula. What did they recommend? They recommend, not surprisingly, in case of ERDS, respiratory failure, isolated respiratory failure, a venous ECMO, peripheral cannulation, bifemoral strategy to limit exposure near the endotracheal tube. This is the last part we can discuss further, but bifemoral strategy, as I told you, it was a recommendation. We do not choose that in our institute. We prefer to have a better flow on the oxygenation of the upper part of the body. And you see also that I told you that the ECMO has to be a rescue therapy. It has not to be proposed at in the first at the very beginning of the therapy of the patient with ARDS. First, non-invasive support, intubation, early intubation, because we want to avoid the spread of the COVID everywhere in the room, and then the prone positioning, vasodilators, and so on. And after unsuccessful flow chart, you reach the ECMO time thanks to a veno-venous ECMO. So once again, it is a rescue therapy at the end after failure of medical therapy. We published our experience in the American Journal of Respiratory and Critical Care Medicine a few days ago. And the question was, in a pandemic context, is it worthwhile, is it worth the effort to derive a lot of medical resources for those patients with our extracorporeal membrane oxygenation? Was it better to use the medical resources for prone positioning or for other patients? So we related and we summarize our activity in this paper quite recently. It was the initial experience between March 3 and April 1. During the month of March, our 5 ICUs in Strasbourg University were connected, and in all, they had 377 ARDS patients to cure, and within this nearly 400 patients, 4.5% had an ECMO insertion. I mean, 17 patients during the month of March had an ECMO insertion. In all, during the pandemic context, we implant 35 ECMOs, but this is related only to the 17 first patients. As I already told you, the preferred approach was a veno-venous ECMO, 16 among the 17. And among the 16 patients, we use 12 Avalon cannula. To remember, single station, neck, and 4 jugulofemoral cannula. 1 VA ECMO because of a cardiogenic shock. And at the implantation time, we had end-stage ARDS because the median PaO2, FiO2 was 71, very low, and with once again a SOFA score rather high. And importantly, all the patients were treated with unfractionated heparin. What do we observe? This is our main findings. This is the main. This figure is our main findings and summarize 1 month of work with the ECMO in our university hospital. After 60 days of follow-up, among our 17 patients, 6 patients had died. I mean, 35% of the patients, which is less than the 60% currently admitted in ARDS patients during a pandemic. Among the survivors, all except 1 were weaned from mechanical ventilation at 60 days, and they have been discharged from intensive care unit. And once again, 3 patients were still hospitalized at 60 days after ECMO implantation, and 7 were discharged from the hospital. Main findings: among the 17 patients at 60 days, 35% of diseased patients, less than the what we find in the literature with in the framework of ARDS. Some very specific point. In this work, we were able to show and to demonstrate that the veno-venous ECMO, it facilitated protective ventilation with decreased plateau pressure, decreased tidal volume, decreased respiratory rate. We compare before and after ECMO implantation, and it has been scientifically proven. We were not able to propose and to use a prone positioning under ECMO. First, because it was not, mandatory, because we improve the oxygenation, and also because we were in a context of pandemia and with an work overload limitation, and we consider that the patient under ECMO had the maximum of the therapy, and it was because they improved their oxygenation, we do not propose the prone positioning. This picture is also interesting to detail a few words. You see that it does not look like a simplified and an extracorporeal circuit that we used usually, that it is currently in use. This is a real console of extracorporeal circulation that it came directly from the cardiac surgery operative room, because in our institute we had 12 extracorporeal circuit devices. It was not sufficient enough. At one point we had 14 patients at the same time that need an ECMO support, and we use 2 of this kind of device coming from the cardiac surgery operative room. Another important point is that concerning this pandemia, as opposed to the H1N1, the COVID-19 was associated with increased risk of thrombotic complication because of a major systemic inflammatory response due to COVID, and it has been also proven an endothelial dysfunction. So we had to use higher anticoagulation targets than we use normally with the ECMO. On the right part of the slide, you see an oxygenator with thrombosis inside a few days after the implantation of ECMO, and we had to change our circuit to make a switch because it was not able to oxygenate adequately anymore. As we increase the heparin, the level of heparin, we had to face some more hemorrhage, with 35% of our patients that had to have a blood transfusion, and 6% that have an hemorrhagic shock because of cannula movement, because of endothelial dysfunction, because of hepatic dysfunction, and so on. But we have 6 patients among this young lady that has that experience an hemorrhagic shock. We have also other adverse events, renal replacement therapy among 10% of the patient, pneumonia under mechanical ventilation, 10% also. So, as a conclusion and to summarize, the take-home message that the ECMO should remain a rescue therapy after the conventional ventilation and conventional medical therapy fails in a pandemic context and in the particular pandemic context of COVID-19 refractory ARDS. We have demonstrated and showed that it reduced the expected mortality from 50, 60 to 30%. It is 20% less mortality. However, importantly, it has to be undertaken in ECMO expert centers with adequate resources and experience in ECMO. And once again, the success depends on a team effort, and it is to answer the question. It is a multidisciplinary team involvement, the surgeons, the critical care physicians, the perfusionists, and the ECMO dedicated and trained nurses, pharmacists, physical therapists, and so on. It is a team effort. I thank you for your attention.
Thank you, Pierre-Emmanuel. Very nice presentation and very impressive data. We have from the audience some question. If you want, I can ask some of
For sure.
The percentage of thrombotic complication, could you remember this data?
Yes, I'm not able to get back. Is it possible to go back?
Thank you, Dr. Fall.
Just a moment.
Yes. It was, if it is possible to go back and come back to presentation, it is 35% of thrombosis. At the very beginning, we were not aware of such a level of thrombotic complication. And after reading the literature from Italy, from China, and from other centers, we little by little increased the anticoagulation target, knowing that we had to face indirectly, we will have to face some other kind of hemorrhage. But it is, sorry, I will come back. It is, I mean, the price to pay it is approximately 30% of patients that has a thrombotic complication. We, the intensivists of our hospital, they publish an article that I did not detail in my presentation, but I just highlight the title of the manuscript. They publish this during the pandemic. It is related to the SARS-CoV-2 infection, and they also clearly demonstrated a high risk of thrombosis in those kind of patients. I mean, 30, 35. It depends on what you are looking for. Not all the patients had for example, of tomodensitometry, chest tomodensitometry, but in each patient for which we had a scanner, a chest scanner, we saw that we saw pulmonary embolism, distal embolism, and so on. So immediately we react by increasing the anticoagulation targets, and consequently we have to face with hemorrhage.
Okay.
That can be severe or not, but hemorrhage.
Okay. Remember that our audience is not only surgeons. There is a question about the ECMO. It's the same ECMO you use for the transplantation?
Not really. It is the same idea, but in case of transplantation, we try to not to intubate there are several times. I mean, before transplantation, waiting for transplantation, if the patient they need an ECMO, we try to use an no yes I try to we try to use the an awake strategy, meaning that we try to we want to provide a minimal oxygenation and decarboxylation, trying to have the patient awake, working with the physiotherapist to have an optimal length of time working, eating before the transplant. So in those particular settings before the transplant, we use awake ECMO and, if possible, an arteriovenous ECMO. If not, veno-venous ECMO. During the ECMO, during the transplant, we use central ECMO. I told you during the pandemic we use peripheral. It will come. We use a percutaneous approach with peripheral. During the transplantation, we implant not peripherally but centrally in the aorta and in the right atrium or cannula during the procedure. And if we experience after the transplantation a problem of organ dysfunction, at this time we implant this in the intensive care unit a peripheral ECMO, most of the time either double lumen or femoroatrial ECMO. I hope I've been clear. It is not the same, definitely not the same setting. The idea of oxygenation and decarboxylation are the same, but we have a lot of tools and we try to implant. We use them on purpose, and the tools are different. In the ECMO tools are different in the framework of a pandemia and ARDS, and in the framework of lung transplantation.
Yes, you are very clear, and the panel will thank you for your explanation. And the last question is: could you estimate if among the survivor, the percentage of patients who will develop a fibrosis in the future?
I was expecting this question, and for us, who are also transplant surgeon, we are expecting a lot. So, for instance, I do not answer, but I mean at least 30% of the patient will experience fibrosis. We have in the patients, in those patients, alive patients, weaned from the ECMO and discharged from hospital, we are following them, and we are beginning to perform chest tomodensitometry. And for instance, the results are awful. A lot of fibrosis, a lot of lung, any kind of fibrosis, and severe fibrosis with impaired lung function. And we are expecting, 20-30% of fibrosis in those kind of patients.
Thank you so much, Pierre-Emmanuel, for your time and for this beautiful presentation. Keep safe.
Thank you.
Thank you.
Bye.
Thank you Dr. Falkers and thank you Dr. Bertolacini. Ladies and gentlemen, the session has now concluded. If interested in CME accreditation, participants should fill in the evaluation form, and pass the CME multiple choice test. To enter the CME section of the site, please close this window, and go back to the ESO website. If you are a mastermind competitor, you will enter the quiz, after the evaluation. The next ESO session, will take place on the 7th of July, at the same time. And Dr. Marie Fallon, of the Edinburgh Cancer Research UK Centre, from Edinburgh, United Kingdom, will discuss with Dr. Carlo Ida Ripamonti, of the IRCS Foundation, National Cancer Institute, from Milan, Italy. The following topic: pain. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.
Thank you very much again, and have a nice evening.